Hello, good evening, everyone. A warm welcome to all of you. I, Dr. Neha Joshi, welcome you all to yet another exciting and engaging seminar being conducted by NSI Mumbai chapter. As we all know, NSI, Nutrition Society of India, was established in 1967, is an association of nutritional professionals, programmers, and policymakers from India and abroad. We have 36 zonal chapters, of which NSI Mumbai chapter is one of the most active chapter dedicated to carrying forward the objectives of the parent body. Today, we are here to commemorate two special events which have happened in this month, that is the International Women's Day and International Kidney Day. As we are all aware, International Women's Day is celebrated on 8th March every year, and International Kidney Day was celebrated on 10th of this month. This year's theme for International Women's Day is Break the Bias, and that for World Kidney Day is Kidney Health for All. So here we are with a very interesting webinar which would highlight both women and their health. We hope you all will enjoy this session and will receive a lot of inputs for your career and professional journey. Topic for today's webinar is women and kidney health. And without wasting any further time, may I call upon Dr. Veena Yadi, Treasurer, NSI Mumbai Chapter, to welcome our today's expert, Dr. Mayuri Trivedi. Over to you, Veena ma'am.
Thank you so much, Dr. Neha. I feel it's my proud privilege to introduce a leading nephrologist and renal transplant physician of India, and she's a very young nephrologist. See, nephrology is a very comparatively a very specialized field of medicine, and there are very few nephrologists and fewer women nephrologists. So we are very, very fortunate to have Dr. Mayuri Trivedi with us to share her expertise with us and tell us something about the women and kidney health. So may I just give me a few seconds? I'll just share my screen and introduce ma'am formally. Okay, and before I introduce ma'am, I would like to thank Mrs. Vasundharaji Raghavan for giving her reference to us, because she said she's the best, you please call her. And so thank you, Vasundharaji. So here we have Dr. Mayuri Dilip Trivedi. She is, as you know, is a medical doctor who has completed DNB in medicine and DM in nephrology. She is a senior consultant and head of the Department of Nephrology at LTMG's Hospital, Sion, that's a Sion hospital. She's also consultant nephrologist and renal transplant physician at Hinduja Healthcare Surgical Center and SL Raheja Fortis Hospital, Mahim. She has, many accolades to her credit and many prestigious places and membership she has. She is on the editorial board. She's on editorial board of a very well-known kidney magazine, that is Kidney News, which is published by American Society of Nephrology. She is a group member of International Society of Nephrology Education Academy. She is also a member of Southeast Asia Interventional Nephrology Working Group, International Society of Nephrology. She has multiple publications and textbook chapters in various national and international nephrology journals in the field of nephrology as well as medicine. Her area of interest are glomerular diseases, pregnancy-associated acute kidney injuries, and critical care nephrology. So I think we are extremely fortunate, madam, to have you here with us. And we will be starting your session soon. Before that, I just want to tell the audience that the session ma'am is going to talk for 30 minutes, and this will be her session will be followed, her speech will be followed by question answer sessions, and Mrs. Anuradha Shekhar, co-convener of our NSI Mumbai chapter, and Dr. Rupali Sengupta will be conducting the question answer sessions. And so please, whatever questions you have, please enter them into the chat box so we can take them well during the question answer session. So thank you so much, and over to you, Dr. Mayuri. Thank you so much for joining.
Thank you so much for that very, very kind introduction. And I hope in the next half an hour or so, I can make some difference to your thinking about women and kidney disease. And essentially, as I was just telling the team before we actually went live, is that my whole aim in the next half an hour or so is to make sure that I put across the point that nephrology, as Dr. Yadi said, that is a very...
sorry to disturb, but you can switch on your video.
Oh, my video. Okay, I'll do that. Right. All right. Hi. So what I was just discussing with the team members right now before we actually went live was that, as Dr. Yadi said, that yeah, nephrology is a very specialized branch, but women with kidney diseases become something that is really super specialized than that. And the reason very strongly being that we are a very, very underrepresented group amongst the nephrology and the kidney care. So without really kind of wasting my time, may I please share my screen?
Yes, please.
Yes. All right. So my topic essentially for the next half an hour is going to focus on women's health and kidney diseases, the challenges that we face and the considerations that we need to give. Now, as Neha told us, before we started the talk, my slide isn't going forward. Am I doing something wrong?
Would you like to stop and start share again, Dr.
Sharing again, yeah, I'll do that. Right. So as Neha just put it to us, that the reason we chose this topic was chosen for this seminar was that we just finished celebrating the 8th of March International Women's Day as the International Women's Day, which was, the theme was that getting over the bias. And the 10th of March this year was the World Kidney Day, where the theme is essentially kidney health for all. And when we say kidney health for all, we mean for men and women too. And the main theme was to bridge the knowledge gap so that we have a better kidney care. And when we say that we have to bridge the knowledge gap, to bridge any gap, we first need to know what we are facing. And that's essentially what I am going to highlight in the next half an hour. Though if I had to just tell you in a more, a humorous frame of mind, I personally don't believe in, the International Women's Day, because any day is our day. Maybe the men should have their day, because we are here, we share half the planet. And if they have a problem, they need to find the planet for themselves. But that is like just talking in jest. So let's go on to the topic as it means. Now, the impact factor, why this topic? Kidney disease affects 10% of adults of the adult population worldwide, that is globally. And it's one of the top 20 causes of death worldwide. So for us as lay people, conventionally, what kills you is cancer, what kills you is heart disease, but the kidney disease is sidelined massively. And we need to realize that out of the top 20 causes of death worldwide, kidney disease is one of them. And kidney disease affects 272 million women worldwide, with only, as a comparative, 266 million men there. So it is a disease that affects women much more than what it affects. And this is not only the data of our country, this is data globally. And it's the 8th leading cause in the list of 1 to 20. It's the 8th leading cause of death, with close to 600,000 female deaths each year. So not only does it affect the morbidity, it also affects the mortality. So this is the impact factor of kidney disease in our life today. Now, strangely, the inequality, the gender bias that exists everywhere else also exists in kidney diseases. So chronic kidney disease is much more commonly seen in women. If a lady and a man have kidney disease, a woman is much more likely to die with kidney disease as compared to a man. Women have lesser access to dialysis as well as to kidney care, and fewer women get the access to kidney transplant also. So here the scenario is women suffer more, women die of it more, but women have lesser access to care and medical care for this disease. So that's why I say inequality exists here also. And that is the impact factor of kidney disease and women. Now, our theme essentially for today's talk is the kidneys and women health. And what I want to tell you is we need to value the fact that this is a disease that affects women more, and we need to empower women to realize that this is a disease that can kill them much more often as compared to men, despite the fact that their access to medical help for these diseases is much lesser. So we need to include them, we need to value them, and we need to empower them so that they can come up and seek medical care for these diseases. Now, what am I really going to talk about in this is the considerations which are related to women's kidney health, the specific risk factors that we face as women for kidney disease, the main challenges and barriers to care for women with kidney disease, and what are the policies and systems we can use to improve the kidney health of women. Because essentially the theme for World Kidney Day was kidney health for all, and women are a part of all. Now, coming to the first topic, that's considerations related to women and kidney health. Globally, kidney diseases are more commonly seen in women, as I said that. And sex differences exist in all aspects of kidney health. So the epidemiology is worse for women. The pathogenesis of kidney disease in women is different and more severe. And care to outcomes is much worse in women as compared to men, because as I said, they have lesser access to medical care as compared to men. Now, the specific biology of women exposes them to unique risk factors. So as I said, the pathogenesis is because of the specific biology is different in women as compared to men. Plus, women get pregnant, and pregnancy itself places an additional burden on kidney health of women. They have lesser access to basic kidney care. I am not even discussing dialysis or transplant, which would be the ultimate kidney care that a patient would require. Even your day-to-day care, even antibiotics in a patient who has a urinary tract infection, women have lesser access to kidney care, which is your bread and butter, probably something that they should receive daily. And poor kidney function is associated with a higher mortality rate in women, because the kidney functions, once they are affected, they decline much faster in women as compared to men. Men remain preserved for a longer period of time with kidney disease as compared to women. And mortality increases both in men and women, but the mortality rates are much higher in women as compared to men. Now, if we see the male-female ratio of kidney disease across all age groups, you see that the ratio is more towards the male. The males get affected more during the third or the fourth decade. But children and the elderly, it is more towards women. More women get affected as children, and more women get affected as in the adults when it comes to kidney disease. Now, at the same time, when you start discussing the mortality risk, say of women and men who start dialysis, it is much against women. More women die with kidney disease, more women die on dialysis as compared to men. And the dialysis, the death may be because of anything. It may be because of CVD mortality. CVD mortality is the cardiovascular disease mortality, so the cardiac illnesses in women who are on dialysis, or even the all-cause mortality, death due to any cause, or even the non-cardiovascular mortality. Everything is more in women as compared to men once they start dialysis. Now, where does India stand? So I gave you the global figures. Now, look here where India stands. 70% of patients who undergo dialysis are men in our country. Delhi, Maharashtra, and Uttarakhand are the three topmost states with maximum number of women on dialysis. So probably as people from Mumbai, we are doing a good job. Okay. Odisha, Madhya Pradesh, and Andhra Pradesh have the least number of women on dialysis, which is, I think, in 2022 is very shameful. Even for a country, we are no longer an underdeveloped country. We are now, counted as the developing country. And in today's world, also, if 70% of our patients are men who undergo dialysis, I think we are not doing a very good job. Now coming to the next form of therapy in somebody who has a kidney disease, that's kidney transplants. So this was anecdotal facts which I came across, which I found very amusing, that in June 17, 1950, the first successful kidney transplant was performed on an American woman named Ruth Tucker. Okay. 4 years later, on December 24th, 1954, there were twins. So Ronald Lee Herrick donated one of his kidneys to his twin brother, Richard. The first recipient of a transplanted kidney was a woman. The first successful kidney donor was a man. So technology back then was gender neutral. It was just seeking to save dying patients regardless of their gender. So Ruth Tucker had received a kidney transplant. So those were the times when there was xenotransplant and they were trying pig transplants and hamster transplants. So the first transplanted kidney, which she survived for a period of 5 days, the recipient was a woman. The first successful donor was a man. So, as I said, science is completely gender neutral. I really don't know who's responsible for the gender bias that we face today, but I know for sure it was not science. And where are we today, half a century later? I just told you where we are. Women lesser on dialysis, women lesser on transplants, women lesser on medical care, women having more disease, women having more mortality. Half a century later, we still have a gender bias, which has a very, very crucial role in not only organ transplants, which I will highlight in the next few moments, that why do I say that there is a gender bias in organ transplants, but we have a gender bias in the general care of kidney patients in our country and worldwide, even today. Now, if we have to share the global kidney transplant scenario, women are less likely than men to be kidney transplant recipients, either from cadavers, that is, you must be knowing from where you take it from a brainstem dead patient, or living donor. Women are less likely than men to be kidney transplant recipients, but they are more likely to serve as living donors for kidney transplantation. There is less likelihood that a woman would come and get registered on the national transplant waiting list. And my friends, this is a global kidney transplant scenario, so you can't blame your country for being backward. The world functions like this even today in 2022. Women are more often donors than recipients. Today, even in my practice, I see more men getting transplants as compared to women. And I live in Mumbai. I practice in Mumbai, which is supposed to be a metro, which is supposed to be an educated, an upcoming, very, very economically forward metro. But today, I tell you, as a nephrologist, I see more male recipients as compared to women. Where does India stand? 80% of organ donors across the country are women. My friends, 80%, only 20% of men donate kidneys to their loved ones. In contrast, only 20% are organ recipients. You see the huge gap that we have to fill. And most common donors are wives or mothers, followed by sisters. Okay. Only 10% of spousal transplants, when I say spousal transplants, is when the one spouse donates his kidney to other, are husbands. It's 90% of the times it is the wife donating to a husband. Only 10% of times you have a husband donating to the wife. There was this study from Delhi AIMS where they did a comparison between male and female kidney donors. So I thought this would be interesting for you in the perspective of numbers. In 2012, you had 82% of patients who were donors were females. In 2015, the number just came down to 75, from 82 to 75. And when you see the recipients, 93% of the recipients were males, which came down to around 79% in 2015. So essentially, we are where we are. Women are kidney donors, men are kidney recipients. And this is, because I'm a nephrologist, I'm talking about kidneys. This is the same literature for any organ donation, including cornea donations, liver donation, lung donation, heart donation. A woman always gives, a man always gives. In the National Organ and Tissue Transplant Organization, where this is the place where you can go and register to donate a kidney, 77.5% of patients, of those who went to donate their kidneys, were females. Only 22% were men. So I hope I have kind of really ground into your head what the gender bias in kidney diseases as well as transplants is today. Now, why do you think this disparity is? Traditionally, so I'm going to talk of India. I don't know why this disparity is there abroad, but I think a lot of factors are common. Traditionally, the male is the bread earner of the family. He's considered to be the bread earner. I don't know whether that kind of still holds true, but he's considered to be the bread earner of the family. In contrast, The lady is always taught to be the nurturer, the sustainer, the giver of life, the mother. Okay. So there are social compulsions. As a lady, you have to give. You have to give your meal. You have to give your love. You have to give your money. You have to give. These are social compulsions. The emotional compulsions. Women always have a higher EQ as compared to men. It's like if my son is suffering, if my son has a kidney failure, I will give. If my husband has it, I will give. If my brother has it, I will give. Women are all givers by nature. In India, we have the sacrificial component. You are the one who has to give it. Why? Because you are the lady. That's it. You are the lady, you have to sacrifice. And of course, the economic disparity. We cannot deny the fact that in majority of houses today in India, the male is the sole bread earner of the family. So if something happens to him, the economic independence has still not gone down to the grassroots in India. The belief is still that the male is the bread earner, and should something happen to him, then all of us are going to die, and therefore the social and the emotional compulsions become much more prominent, because the male has to survive, because he is the one on whom everybody else is dependent. Now, next we go to the gender-specific risk factors for kidney disease. I really like this saying which I had come across, is that the problem with gender is that it prescribes how we should be rather than recognizing how we are. As women, we don't realize the gender-specific risk factors we have. We have just been taught to be strong, and we choose to not accept the risk factors that we are. We just choose to be in denial that no, it's okay. I mean, nothing. If I'm having swelling in my leg, it's okay because I stood for so long. A woman would take a much longer time to seek medical help as compared to a male. And this is what science has proven. So this is not something that is presumption. This is something that multiple papers have proven, that a woman all over the world would take much longer to seek a doctor's help as compared to a male. So what are the gender specific risk factors we have? So there's the urinary tract infections. As we all know, women are much more predisposed to urinary tract infections for the simple reason that the female anatomy and physiology predisposes her to higher incidence of UTI. Plus, poor personal hygiene, access to personal care products predisposes. We all know how poor is the access at the grassroots levels to personal care, including menstrual hygiene for women. And that kind of predisposes women to a higher incidence of UTI. And we have to remember that recurrent UTIs, inadequately treated UTIs, or inappropriately treated UTI predisposes you to chronic kidney damage in the long term. The impact factor of a urinary tract infection, as I said, I'm going to give you numbers so that you are convinced about what I'm saying. It's the most common infection that a healthy woman of all ages throughout her lifespan will be exposed to. 10% of young, sexually active, premenopausal women experience at least one UTI each year. And 60% of all women will have at least one or more of such infection in their lifetime. So 60% of women as compared to men who have an incidence of less than 0.1% per year. So this is the impact factor of a urinary tract infection. And around 5% of women who have UTIs may have what we call as a recurrent infection for at least some period of time. And the higher the incidence, the more severe infection, the higher is the chances that your kidneys are going to get affected because of a UTI. They are often overlooked or trivialized, especially in children. So as I said, women of all ages are more prone to UTI as compared to men. And as I said, it can lead to scarring of your kidneys, it can lead to hypertension, and eventually, if left unaddressed, it can cause chronic renal failure in the long run too. Especially during pregnancies, if you have UTI, it may lead to worsening renal functions in the mother, hypertension in the mother, and the fetus also may get affected, including the patient. The fetus can have intrauterine growth retardation, which can eventually lead to intrauterine fetal death also. And UTIs occur very, very commonly. The incidence shoots up to almost double in menopausal women due to the estrogen deficiency. So UTI is something from the womb to the tomb, every woman has to be extremely aware. What are the symptoms of urinary tract infection? Most common being totally non-specific. Back pain, flank pain. Every woman has back pain sometime in their life. Lower abdominal pain, high-grade fevers with chills, burning urine, blood in the urine, turbid urine. These are the most common symptoms of urinary tract infection. And please, please, please do not ignore them. Don't let your patients also ignore them. Don't let the women you know who are around you, whom you support, whom you know, whom you have befriended, ever ignore a urinary tract infection, because it is much more than an infection. Now, next, coming to the other most common risk factor that a woman is specifically going to be exposed to, that's pregnancy-related renal diseases. 15 to 25% of acute kidney injury in our country is because of pregnancy-related renal diseases. And it is the most common cause of AKI in women of childbearing age, that is between 15 to 45% of 45 years of age. 3 to 7% of women would have AKI because of pregnancy. 8% of maternal and fetal deaths in India are because of acute kidney injury. And the most common cause in today's world, in 2022 also, is septic abortions. Septic abortions cause AKI in pregnancy in our country, even today in 2022, which is extremely shameful. Because remember one thing, pregnancy is a physiological condition. Pregnancy is a woman's dream, and she cannot pay at the cost of her life. She cannot be pregnant at the cost of her kidneys. She cannot become dialysis dependent at the cost of just a pregnancy, just the dream, just the wish that she wants to become a mother. So these figures are big, and these are figures that you are reading in 2022, that is today. And if you have septic abortions that are still happening in our country, I think we are going wrong. Now, what are the various, apart from abortions, of course, apart from septic abortions, which are the most common, what are the other causes of pregnancy-related kidney disease? Infections being first, illegal abortions without infection, just illegal abortions, which cause bleeding, which cause local injury. Teenage pregnancies, the teenagers are not, their body cannot support pregnancy there. High blood pressure during pregnancy, blood loss, massive blood loss, not a registered pregnancy. They going to quacks for their delivery and having local injury, not able to control the blood loss. Specific diseases of pregnancy which come only in pregnancy, like lupus nephritis, like various glomerular diseases, may cause pregnancy-related kidney disease. Now, if you just had to eyeball the etiologies of PRAKI, that's what it's called, pregnancy-related acute kidney injury. The most common is sepsis, followed by pregnancy-induced hypertension, that's PIH, followed by DIC, that is disseminated intravascular coagulopathy, that's your bleeding and the other the blood-related complications of pregnancy, followed lastly by antepartum hemorrhage or postpartum hemorrhage. So if you see across the data across years from 1982 to 2014, the incidence of AKI has increased. It has gone almost 3 times, but the pregnancy-related AKI has still remained the same. It is 65%. It is 65 patients out of the 426, 125 patients out of. So the figures have come down, but they still exist, which is shameful. There's no this thing. So definitely our care for women who are pregnant has improved. When we see the percentage of AKIs over the year, it has come down, but it still exists, which is a shame. Now, if we had to, if the figure that I showed you as a graph, if I had to show you as a pie chart, in 1982 to 90, so in the 80s, post-abortal AKI, so as I said, the septic AKIs were the blue part of it was 65.1%. We went to the next century where still it was the post-abortal, and we come to the current century and it is just behind puerperal sepsis. So we are still where we started. And as I said, septic abortions and illegal abortions are the most common cause of kidney disease in pregnancy in our country, in women of childbearing age. Now, what are the various things that a pregnancy can do to the kidney and to the mother? It can cause maternal death, and the death can be anytime within the pregnancy, after the pregnancy. If the patient already has kidney disease, she can progress to requiring dialysis. If she has immunological diseases, there will be flares. So you have lupus nephritis, you have autoimmune thyroiditis, these diseases are going to flare during pregnancy. If the patient is a transplant recipient, she may have an acute rejection of her transplant and a kidney failure during pregnancy. Just the fact that she has kidney disease and she's pregnant may lead to abortions, may lead to stillborns, may lead to perinatal deaths, and may lead to birth weight issues in the child. You also can have malformations in the child if the mother has a kidney disease. If the mother has a hereditary kidney disease, she may pass it on to her child. And the mother may remain hypertensive for the rest of her life if she develops hypertension during the pregnancy. And eventually, this hypertension may lead to a chronic kidney disease in this woman later in her life. And what was her fault? Her only fault was she decided to be pregnant. So these were what I just enlisted. Now, I'm going to spend one slide on pregnancy-induced hypertension or PIH, because this is a hypertensive disorder of pregnancy, which is associated with proteinuria and kidney involvement. And it is seen in numbers as high as 10% of all pregnancies. And as I said, there are fetal and maternal consequences of this, and it can be hereditary. We have to realize that pregnancy-induced hypertension may lead to chronic renal failure, as I said, in the long term. And why is it important for the nutritionists? Is because these are the patients who come to you, and we know that India is essentially a malnourished state. They come with iron deficiency, anemia is the rule. But these are patients whom you will have to control the salt, because salt is something that is going to lead to more water retention. Salt is something that is going to lead to more hypertension in these ladies, and salt is going to lead to the progression of the kidney disease in this women. So apart from the usual, the folate and the iron deficiency that as a nutritionist, and the protein intake as nutritionist that you kind of concentrate on, you have to do the salt restriction in these patients. Now, what are the usual symptoms? They'll have sudden weight gain, there'll be protein in urine, they will be swollen up. Essentially, the last stages of this would be where they would present with seizures and coma. What are the fetal complications? Preterm babies, low birth weight babies, intrauterine growth retardation, renal failure, stillborns, abortions. And I'm going to spend some time in the next few slides on the intrauterine growth retardation. If a child is growth retarded intrauterine, how does that affect the kidney? So what is the only solution? Regular and appropriate antenatal care for these mothers, for all mothers, not just mothers who have a kidney disease. Systemic autoimmune disease, as I said, SLE, rheumatoid arthritis, Sjogren's, scleroderma. These are diseases in which the immune system of the body malfunctions and starts attacking the cells. And these are usually the diseases which affect the joints, and they also affect the kidneys. And unfortunately, these are diseases which are seen more commonly in women in all ages, reproductive age, perimenopausal, menopausal, all are more frequency in women. And what are the symptoms you look for? Swelling, froth in the urine, blood in the urine, joint pains, skin rash, weight loss, recurrent pregnancy loss, or primary infertility. As I said, female to male ratio is massively different, much more common in women at all strata of life. CKD, most common disease, ultimate endpoint of any kidney disease. You may have recurrent UTIs, you may have pregnancy-induced AKI, you may have an autoimmune disease. Endpoint is CKD, and it is a relentless progress which eventually is going to require some form of renal replacement therapy, either dialysis or transplant. What are the risk factors for kidney disease in women? As I said, autoimmune disease, diabetes, obesity, metabolic syndrome, much more common in women as compared to men. Renal stones, much more common in women as compared to men. Urinary tract infections. What are the cardiovascular risk factors which are unique to women? So they also have the normal ones, but unique to women, postmenopausal status, their exposure to oral contraceptives, their exposure to hormone replacement therapy for whatever reason. Pregnancy-related kidney disease may ultimately become CKD. Hereditary diseases seen more often in women as compared to men. What are the lifestyle risk factors? We are now getting progressive. Smoking, alcohol, sedentary behavior, much more common in women. Obesity. The over-the-counter drug use. This is something that is very, very common in women for the simple reason because women don't come upfront for medical care. They're like, I'm having a headache, go take a painkiller. I'm having knee pain, go take a painkiller. Who has the time? Why waste money? Why go to a doctor? Use of alternative medicines, Ayurvedic, homeopathic. Why waste money on allopathic? Some Baba Churan, ye kha liya, laga liya, we are good. Radiation exposure. In case they are exposed to radiation, they, in whatever form, they may be more prone to kidney disease. What are the consequences? There is an increased risk of you requiring dialysis or transplant. There is an increased risk of cardiovascular disease in these women also. You will also have a more higher chance of having CKD, mineral bone disease, that is your bone fractures and osteomalacia, osteoporosis, hormone-related complications, irregular menses, reduced fertility, reduced libido. This is a factor which is very, 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 it's a blind spot. How can a woman talk of sexual desire? How can women talk of libido? But these are also factors which have to be considered in women. Risk related to pregnancy, we already discussed that, and the chance of transmitting hereditary diseases to your offspring. So what are our learning points? As nutritionists, CKD is very often overlooked, especially in the older women. In India, I would say even in the younger women, because of the decreased muscle mass. So we know that in women, it's more of subcute fat as compared to muscle mass. And since they don't have a muscle mass, their creat, so a 1.5 creat in a male and a 1.5 creat in a female is totally of different consequences, because a woman doesn't have that much of muscle mass to generate that much of creatinine. So when her creatinine is 1.5 with a lesser muscle mass, she has a much more advanced kidney disease as compared to a male with a 1.5 creatinine. Also, obesity is much more common in women, and therefore they are at a much higher risk of getting a kidney disease. Non-gender specific risk. So we definitely have our share of gender risk, but the non-gender specific risk factors are also more common in women. Diabetes, hypertension, renal stone disease. As I said, use alternative medicines, use painkillers, do over the counter, don't go to the doctor. Who has the time to waste? Obesity and hereditary diseases, much more common in women as compared to men. Now, what are the main challenges and what are the main barriers that exist for kidney care for women with kidney disease? Coming to this, so coming to what are the how do we kind of as I was saying, that how do we correlate, from the womb to the tomb? So let's start from the center of this figure, that is the preterm birth. A child has a preterm birth. Why would a child have a preterm birth? If the mother has a kidney disease, if she's a donor, yes, kidney donation may lead to pregnancy complications, which is never explained to the mother. Maternal BMI, our women are always malnourished. If they have alcohol consumption, if the maternal education is less, if they are somebody who smoke, all of this can cause chorioamniotitis, that is the infection of the chorionic membrane, intrauterine growth retardation in children, maternal diabetes, preeclampsia and the pregnancy-induced hypertension, all leading to preterm births. When a child is born preterm, he has impaired development. He may also have renal injury in his postnatal life. Why? Because he has decreased nephron numbers. Because he is intrauterine growth retarded, the child's nephron numbers are lesser. When he grows up, he will develop renal dysfunction and hypertension. If, God forbid, this is a lady, this is a girl child who is born, who has all of these, decreased nephron numbers, decreased renal, obviously, so with renal dysfunction, she is going to become a mother, and she will give rise to all of these factors in the next generation. So from the womb to the tomb, the lady is exposed to so many risk factors for kidney disease. Again, I don't know why this is not sharing. I'll stop the share and reshare it. I'm sorry for this, but technically I don't know what is the issue. I'll just reshare it again. So my screen is So as I said, from the womb to the tomb, these are the factors that the patient is going to, the lady is going to share. And the cycle is again going to be endless, because maternal education is something that is very poor in our country. And diseases like malaria, dengue, HIV, we have deaths because of these diseases. Severe maternal anemia, this has nothing to do with kidney diseases. Our women have anemia to begin with. And all of this, along with a preterm birth, will lead to impaired development, renal injury, lesser nephron numbers, renal dysfunction and hypertension in the child, and eventually she will develop a kidney disease and go through this entire cycle again for her next generation. So a sick mother gives birth to a sick child who eventually grows up to give birth to yet another sick child. So you understand the cycle which needs to be broken. Now coming to the sex difference in the continuum of kidney disease care, what is the difference? There is a gender difference in access to medical care, and there is absolute lacking of data to evaluate the extent of these differences. So the access to medical care is much more for males as compared to women, despite the fact that more number of women have CKD, more number of women would progress to get dialysis. However, they have lesser access to dialysis as compared to women, and more number of women require kidney transplant. But again, more often a woman is a donor as compared to a recipient. Now, just to kind of sum up what I just said, we have non-gender specific risk factors which are more to us. We have increased susceptibility to risk factors which are gender specific, as I said, UTIs, HIV infections, autoimmune diseases like SLE. We have limited access to care, more number of women becoming CKD, again, limited access to care. So even if they have an acute kidney injury because of all of this, they have limited access to care, and therefore they will become CKD. Further limited access to care, they become end-stage renal disease. They have limited access to dialysis. There is no gender-specific treatment targets. Menopause itself causes a much poorer prognosis in these women, and more likely, because of obesity, because of metabolic syndrome, these women are to diabetes, higher amount of mortality. The same thing happens because of the educational and the economic and social disempowerment that women have. They do not have informed health choices. They just do it because their husband told them, their father told them, their brother told them. Lack of funds which are specifically for women. They have more AKI, again, limited access to care, turns to CKD, turns to ASRD. You come back over here. You see any blocks in this share eventually leads to AKI, limited access to care, leads to CKD, turns to ASRD, and we come back here. So these are all the social, economical, educational, medical factors why women make such a special group when it comes to kidney diseases. Now, barriers to research. So all this time I spoke about medical care. Now, why are there barriers to research about women? Women are considered to be the primary caretakers of the family. So there is a reduced participation in clinical trials. They are like, you sit at home, take care of the family. You cannot keep going and going to the hospital, taking part in clinical trials, taking part in educational programs. You can't do that because you're the primary caretaker of the family. This is more because of the lower literacy and the awareness. What is the end result? The end result is that we have lack of women-centric data. What we do today is extrapolation of data of what is being done on men is what is extrapolated to women. And absence of data, research data in pregnancy and breastfeeding. There is a massive void because one, there is reluctance to participate in research due to fear of postponement of pregnancy or the burden of visiting. Again, the same thing, because you are a primary caretaker, you can't take up the burden of monitoring and regular visits, or you have to finish your pregnancy irrespective of what your health is, and you cannot take part in clinical data, you cannot postpone your pregnancy, and therefore absence of women, lack of women-centric data is a problem that is globally faced today, even in the subgroups of pregnancy in breastfeeding women. Now, what are the policies to overcome these barriers for kidney care in women? So as Malala, she said, we realize the importance of our voices only when we are silenced. When we face it is when we realize it. So what can we do? We have to have awareness campaigns to increase the knowledge about burden of kidney disease in women. As medical caregivers, even as nutritionists, you need to talk to your patients about it. You need to tell them how important it is for them to monitor their kidney health. Engaging government, women rights group, like what Vasundhara does, what she right now does is she voices the women's rights in all her patient awareness groups. And the community as large, you have to highlight the vulnerability of a woman, including the fact that there is lack of access to healthcare. Safe motherhood should be a norm for every woman, but definitely for women with kidney disease, including adequate nutrition, effective antenatal care, family planning should be offered to them, and educational, economic, and social empowerment of these women so that they are capable of having informed healthcare sources. They should be a part of the healthcare that they choose. Now, what we usually say is better education is what leads to better access to medical care. So each one teach one. Discourage teenage pregnancies, discourage young age marriages. Delayed and inadequate medical attention should not be encouraged. Lack of sexual education. Tell me how many of our children, maybe the schools today are much better than the times when we got educated, or maybe our seniors got educated. Sex education was never considered to be important. We have to encourage, we have to insist that they use contraception, irrespective of what their families think. Offer them safer abortion practices, MTP, use of intimate hygiene products, menstrual hygiene, adequate nutrition. They cannot be the caregiver and not take. They cannot be the people who take care of their family and not be offered adequate and good nutrition with pregnancies, without pregnancies. Antenatal and postpartum care. If you see a woman who is pregnant, she has to have access to encourage registered pregnancies. They should have access to genetic counseling because they are at a higher risk of hereditary kidney diseases. They should have regular BP monitoring and urine examination throughout their pregnancies, safe delivery practices, safe abortion practices. And women who do not lose weight by 3 to 12 months of post-pregnancies have a much higher rate of kidney diseases as well as heart diseases. These are patients who require to be monitored. Women who do not lose weight are the patients who come to you as nutritionists. Make sure you screen them for kidney diseases and heart diseases. And frequent long-term follow-up is necessary for women who have developed high sugars for pregnancy. These are women who come to you as nutritionists. Make sure that you screen them for a lifetime for developing diabetes, metabolic syndrome, as well as kidney disease. For women of all ages, annual health checkup, encourage that. Ensure vaccinations and against TB, against hepatitis B, against HPV, human papilloma virus, because these are all viruses and bacteria which directly cause kidney diseases. We must have laws which protect women against coercion and enforce kidney donations. If you find when the kidney recipients, kidney donors come to you and you feel that there is a force, as women, we have a very, very, very good sixth sense. If you feel, inform the police, inform the social workers. Don't encourage coercion or enforce kidney donations. Health schemes and women-based policies which are specifically directed at women for kidney care, which should include all forms of dialysis and transplantations, are something which are the need of the hour as of today. Now, as nutritionists, all I'm going to tell you is common salt, the white poison. Excess salt is a risk factor for hypertension, for heart disease and kidney disease. It leads to water retention and high blood pressure. Educate women to lose less salt. It is, as we had this, I'm sure you know what has to be done when it comes to ensuring low salt, but we had this momentum which had gathered amongst the nephrologists of the country, which said, bus ek chammach kam. And that is what we were telling our patients, that you just need to reduce your salt by 1 spoon. And that is the white poison which is eliminated from your diet. Avoid kidney toxic drugs, painkillers, and over-the-counter drugs. Avoid Ayurvedic and herbal drugs without monitoring. Avoid protein supplements, especially steroids and the protein supplements, which are so commonly given in the gyms. And these are the younger generation. They come to you for weight loss. They have these fad diets. They are taking protein supplements. Please, please, please make sure that they are not doing that. If they have a family history of kidney disease, of stone disease, of metabolic diseases, regular screening of the women. And if you feel that they have risk factors, they have recurrent UTIs, screen them for kidney disease also. Our generation does tend to smoke and drink. It's no longer a male's purview. Stop smoking, stop drinking, stop extreme diets and weight loss, the slimming medicines. These are patients who come to you. This is where you can make a difference. Essentially, the take-home message for me today is women have unique risk factors for kidney diseases and kidney disease. We need to respect that. Please, 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 as women yourself, do not ignore them in yourself as well as your female patients. And we have to accept that disparity exists in access to healthcare, including dialysis and transplantation. The issues which are related to access to healthcare have a profound impact on today as well as tomorrow, on our forthcoming generations also. And advocating for improved access to kidney health is something that is the need for the hour for women. And this is necessary not only for women's health, but if we want to maintain the health of our coming generations of families, communities, and the population, because it is it's essentially, I always say that it's the girls who make the world go round. So if we want the community and our population to be healthy, we need to make sure that our women are healthy. So I'm going to stop my talk here with this saying, which is one of my favorites. So here's to all of us. Here's to strong women. May we know them, may we be them, and may we raise them. Thank you very much for a very, very patient hearing, and I'll be happy to take questions.
So I think that was the most amazing lecture that I have heard. And I'm very proud of Mayuri Trivedi being a woman talking so passionately for the upliftment of other women. So you have done justice, not only for the topic that you have been given, but the way you spoke about it requires to be heard by even, I think, the doctors community. Because my first question is that when we all know that these kind of things are going to cause kidney disorders, none of the doctors actually give us any kind of an indication that I need to get my kidneys checked. So what are your thoughts about that?
You need to change your doctor then. Okay, that's just on the thing. But I would not really generalize this statement. I mean, jokes apart. But this is something that needs to be done. And I am surprised that in today's world, this is not something, you probably have, come across a doctor who is not probably, passionately involved in what he does. But yes, a doctor, even at the level of the doctor, even at your level as a nutritionist, as somebody who's a paramedic, it is our duty to make sure that we get this message across, that these are the risk factors as women. And the risk factors that I spoke about today was for kidney disease. But believe me, a large part of these risk factors also hold true for cardiovascular diseases, for other metabolic syndrome. These are considered to be the diseases of modern age. It's our grandmothers and great grandmothers never died of heart diseases or kidney diseases. They were healthy. But these are the diseases, and yes, you need to make sure that the message goes across.
Thank you for your view on that. The second question comes from Madhvi Sathe. She says, could iron deficiency anemia be one factor setting off pre-eclampsia and eclampsia and kidney complications during pregnancy?
Absolutely. So anemia is something that has been associated with a higher chance of eclampsia and pre-eclampsia. And of course, once the patient gets eclampsia and pre-eclampsia, he automatically kind of is a high risk for kidney disease. Though we've not really been able to associate if there is an association, but there is no causation that has been proven. But yes, iron deficiency anemia is something that predisposes a woman to pregnancy-related complications, including pregnancy-associated hypertension.
So what is your take on people who keep popping pills for even simple headaches and migraines and things like that?
That's exactly what I said. That's exactly what I said. That, especially for women, we take it personally, to go to a doctor, headache hai, kha liya, did this thing. This whole not taking care of yourself or feeling guilty about taking care of yourself is exactly what I wanted to highlight, because painkillers are something that need to be taken under a doctor's supervision. Slimming tablets, Ayurvedic, homeopathy, all of this is something that needs to be taken under supervision. Unfortunately, there is no quality control for alternative medicines in our country. Anybody can become an Ayurvedic. I'm not saying that allopathy has a great quality control, but it is much, much, much more controlled as compared to Ayurvedic and homeopathy. And the reason why these uncontrolled medicines, when they go to the patient, cause kidney diseases, because they are contaminated with steroids, they are contaminated with heavy metals, they are contaminated with things like mercury, and this is what affects the kidney. So over-the-counter drugs, any drug can cause kidney damage, should not be taken as an the pharmacists have no business giving over-the-counter drugs. You will be surprised as to the actual list of over-the-counter drugs is less than 5% of your entire pharmacy. But I know of being a doctor, I know that things like steroids also are given over-the-counter. So that is what we need to know. And this is unfortunately something that is seen more commonly in women in our country is because of the guilt complex that how can I be ill? How can I seek a doctor's help? How can I waste time? How can I waste money over something as non-specific as a headache? But you never know. A headache may be a harbinger of a kidney disease, maybe a harbinger of something neurological. So don't ignore it. That's all that I'm saying. Yes.
Absolutely. I'll take one more question before I pass it on to Rupali. The next question is regarding kidney problems. Are there any raise in kidney problems seen in people who have been treated with COVID medicines?
Yes.
COVID medications.
So COVID medications, they all came with a bang, and every new medication was considered to be the next elixir of life. And today we are left with nothing having scientific evidence except the vaccine and to a limited extent, the steroids. A lot of medicines like the Fabiflu or the Favipiravir and even Remdesivir to that extent did have some effect on the kidney, but it was not an absolute contraindication, and it was chosen case based. But yes, the COVID, we had a lot of patients taking high doses of vitamin C, which was considered to be an immune booster. And we suddenly had a rise in the number of patients who came to us with kidney failure. And the only thing they had done was high doses of vitamin C, which typically causes what's called as oxalate nephropathy. It causes a higher incidence of oxalate stones in the kidney, which eventually leads to kidney damage. So something as non-specific as vitamin C, which a lot of us were prescribed as the immune booster and it's going to save you from COVID, ended up with patients having kidney failure.
I think even vitamin D.
I think this CADA was into that role during the COVID times when most of the people were used to taking that CADA concept.
And we didn't know what the CADA contained.
Yes, and the decoction of CADA is still unknown to us.
So I think I'll pass it on to Rupali to take the next question.
Yeah, I have one question from Dr. Subhadra. She has asked, can uterine and vaginal infection affect kidney health?
Yes. So what happens is with recurrent vaginal infections, what we have is sexually transmitted diseases. Eventually, if you see the anatomy, is what exactly I said. The anatomy of the female genitalia is that the vaginal opening, and so the vaginal opening and the urethral opening, from where the urine comes, is very, very, very close by. The distance between them is less than 1 centimeter. So if a patient has recurrent sexually transmitted diseases or vaginal infection, eventually he is going to have. So traditionally, if a patient comes to me with recurrent UTIs, I am going to refer the patient to a gynecologist to rule out a vaginal infection because they are interchangeable. A vaginal infection can lead to a UTI. Recurrent UTIs can lead to a vaginal infection. So yes, they are definitely interconnected.
The next question is, what are the various reasons for high creatinine in blood and what can be the management of the same?
Okay, so whoever's asked me this has asked me a very, very broad based question. And, probably it took me 13 years to get my degree. So maybe, you can start today and you will get it. But anything that can cause kidney damage can cause a high creatinine level. And depending on what has caused the kidney damage, whether it is acute or whether it is chronic, whether it is which part of the kidney is damaged, what is the etiology that has caused it, your treatment is going to vary according to that. So there is no treatment per se for high creatinine. It's not the high creatinine that you treat. The high creatinine indicates a kidney disease and it's the kidney disease that you treat. So depending on what has caused the high creatinine, your treatment would vary.
And the another question comes to me is, how can we avoid and prevent UTI in menopausal women from your perspective and experience?
Okay, so menopausal women, because of the estrogen deficiency, would have a higher chance of having vaginal discharge, would have a higher chance of having vaginal infections. So make sure that they don't have it. Two, local estrogen creams may be used for these patients because estrogen deficiency by itself causes certain anatomical changes, certain physiological changes. So a local estrogen creams may be prescribed for these women, and of course, personal hygiene. So these are the three main things that you need to do. And usually the postmenopausal women are the senior citizens, or are the, by age, they would be, beyond 50, 45, 50. So, screen these women for metabolic syndrome, because this is the most common age group where they get diabetic, and make sure that you control your diabetes. So these are all the factors that specifically you can do in a postmenopausal woman to avoid UTI.
I take up this question, then I will switch over to Anu ma'am. Will you please explain the rationale for avoiding protein supplements for gymmer?
Okay, so
is it for normal individual or for those having a kidney issue? I think
right. So definitely for those who have a kidney issue. But of late, we are seeing a lot of younger generation. So when I see a younger generation, that is between the age of 20 to 25, they are into this severe gymming and having the excessive protein. So you have to remember that the proteins in the body are handled by the kidney, and there is a physiological limit that the kidney can take when you give excess of protein. We see these patients taking proteins at 1.8 grams per kg per day, 2 grams per kg per day. And these may be animal proteins, these are with essential amino acids. So amino acids like glutamine are known to cause hematuria. So any excess of protein. So a patient who has kidney disease, the first thing that you do is you restrict the amount of protein they take. A normal protein intake would be around 1 to 1.2. You restrict it to 0.8 to 1. The reason being, excessive protein causes what is called as hyperfiltration injury in the kidney, and eventually can cause kidney damage. So for normal individuals, as well as definitely for patients who have a risk factor for kidney diseases or who already have a kidney disease, but even for normal patients, there is a finite amount of protein that the kidney can handle, and you cannot go beyond that. So if you go beyond that, the chances that these patients may develop hematuria, may develop glomerular injury, may develop hypertension, eventually leading to kidney damage, is very high.
So now let me take the last question of the day, but this is more towards nutrition. There is a girl called Zainab who wants to ask you, do refined oils have a role to play with kidney disease?
So I am going to essentially leave that to one of the nutritionists to answer. But for me as a nephrologist, I don't care what oil you use, as long as the oil that you use is within the recommended amount. But the refined oils per se do not have any direct connection to any of the kidney disease. Now, there are certain kidney diseases which are said to benefit with with omega-3 fatty acids. Essentially, there's a disease which is called as IgA nephropathy. And for that, we do give patients the fish oil and omega-3 fatty acids as a part of the treatment regimen, because it is known to that. But otherwise, literature at least does not define any correlation or causal association of refined oils directly with kidney disease.
So thank you. We come to the end of your session today. And if you can see the chat box, there are some very amazing comments coming over to you. So we thank you for taking the time and coming to our MSI platform and giving such an amazing and a very, very beautifully, concised way of arranging your PPT as well. I really enjoyed. And the passion with which you speak, Mayuri, is tremendous. I mean, it just is so very, I think it has come on to me as well, because I'm so very delighted. And I don't think none of us even switched off our laptops or wherever we are watching from. I think you deserve a standing ovation from me, actually. But since I can't stand right now, you did a fantastic job. So thank you once again for accepting our invitation and being here with us and so passionately talking about what you really, really love to do in your life. And we in NSI promise that we are going to call you whenever we want to educate the masses regarding this particular very important topic where women are generally neglecting their health. And as you said, women are the givers, and you proved it through your PPT as well, that women do give a lot more than men do. So thank you once again. Thank you. Thank you so much.
Thank you so much.
Thank you very much.
And now I invite Shubhadra Mandalika to take over from here. So Dr. Shubhadra.
Thank you so much for having me. And it was an absolute pleasure. And I would love to be a part of your academic sessions because this is something that I really enjoy. Nephrology is something that I really enjoy. Thank you so much for having me.
Thank you. And we wish you all the best.
Thank you, Dr. Mayuri. And thank you, Anuradha, for inviting me now on the session. And yes, as a convener of the chapter, I'm here now today with all of you to fulfill some of my responsibilities. As I've shared with all the members on the respective groups, the current local executive committee is going to complete their term. So we are celebrating that. And while completing the term, I would like to share with you all our thoughts and all our achievements before announcing the new team who will be taking over the chapter ahead in the future. Let me share the screen once. Yes. As Dr. Neha Joshi already said, and I have been saying several times on this platform, yes, our chapter is one of the most active zonal chapters. We are very proud of it. And this one fact which we realized, and the feedback which we have received from several of the participants of our programs as well as other zonal chapters of Nutrition Society of India has motivated us further and further to plan more motivational programs and more useful programs that has benefited so far various sections of the community. And I'm very happy to speak to you on behalf of my team so far and the current local executive committee team, the office bearers, including myself as convener, Dr. Subhadra Mandalika, and I'm supported with all my vibrant team members, Secretary Mrs. Anuradha Shekhar, Treasurer Dr. Veena Yatri, and Co-Treasurer Dr. Neha Joshi. And we have experienced nutritionists in the local executive committee members team, Dr. Meena Gudia, Dr. Madhavi Sathe, Mrs. Shama Chavan, Dr. Rupali Sengupta, Dr. Anuradha Mitra, Dr. Neha Sanbalkar, Dr. Zubeda Tudli. And of course, I cannot complete giving details about my team without mentioning about the social media and webinar team who have been our strong support in all our activities. So we have several youngsters with us and who were not only the technical support to us, but who have become part and parcel of the local executive committee directly as well as indirectly. And they are responsible for our today's social visibility. And as a formality, I would like to share with you some of our constructive efforts during as well as post-lockdown period in the past 2 years, because 2 years is actually the term of local executive committee as per the instruction of Nutrition Society of India, the parent body. So we have conducted various activities, including community outreach programs, and we have conducted several scientific sessions in the form of webinars, and we have also come up with certain publications. So this lockdown period, it has been used by all of us as an opportunity to benefit the community as much as we could. So the various community outreach programs included the sessions, the workshops and interactive sessions during breastfeeding week in collaboration with Nourish India and Niramaya Health Foundation. And also we have never stopped celebrating the World Yoga Day. And we have had eminent experts to talk to us about the importance of yoga. And this has been supported by our direct or indirect community activities, wherein we have brought up a publication including nutritional modules that could be used for educating the Anganwadi workers on how to pass on the nutrition information to the ultimate beneficiaries. And we could also conduct a training program of the trainers online, and which has been supported by various experts who are all life members of our Nutrition Society of India. And we have come up with several publications which can be downloaded from our website. A compilation of the excellent compilation of indigenous nutritious recipes. This we have prepared in response to the invitation from Ministry of Family Welfare, Government of India. And as many of you are aware of, we have been publishing evidence-based information in the form of social media posts on our Facebook and Insta. And all these we have compiled them. Most of them we have compiled them up to the year 2020. And this is available as an album on our website, and which will be having great educational value to all the nutrition enthusiasts. And there are about 50 plus webinars that we have conducted, and among them 26 and above are just standalone webinars, individual webinars. And there were 4 very, very important webinar workshop series, besides several other training programs that we have conducted. So these are all the various individual webinars, that is standalone webinars, wherein you can see that there were eminent experts both from India and abroad. And all these sessions have been very highly appreciated. And in fact, we received feedback of repeating certain sessions, but several of these sessions are still available on the YouTube, and we keep receiving the views on the YouTube for most of these sessions again and again. And let's know about a little bit more about our webinar workshop series that we have organized. And Nutrition Society of India, one of the objectives is to support and encourage the research interest in nutritionists. So keeping that in mind, the research skill, we have conducted webinar series on research skills, that is including nutrition assessment series, wherein the different types of nutritional assessment procedures were dealt with by eminent experts who were very strongly associated with nutrition research. And then we have also conducted research series in qualitative as well as quantitative research workshops, during which eminent experts share their expertise. Practical tips were given during these workshops as to how to carry out the qualitative as well as quantitative research, and how to do the referencing, how to write the research reports, etc. And of course, we cannot forget the National Nutrition Month, which is a big celebration for all the members of Nutrition Society of India. We have collaborated with esteemed educational institutions for conducting various programs. Of course, in the year 2020, we could not collaborate with other organizations, but still we have conducted very important sessions which are more relevant to the COVID-19 situation, at the same time the general health of population. And later on, we have conducted programs during National Nutrition Month in 2021 in collaboration with Dr. BMN College and College of Home Science and other academic institutions, including Nirmala Niketan College of Home Science, etc. And also the Srimati Maniben Nanavati Women's College. All these programs, during all these programs, eminent experts from the field of nutrition and medicine and also dietetics have shared their expertise, and which has increased the interest of nutritionists in this field. And besides all these programs, we have conducted various student-centered activities and contests, and which has received applause and which has received a lot of participation from across India. So our programs have attracted not only the students and participants from within Mumbai, but it has attracted participants from outside Mumbai, from all over India, as well as sometimes the webinars we also had. Many times we had international participants as well. And one of the excellent programs that we have conducted, or I should say, one of the most important activities that we have conducted was we paid tribute to the frontline COVID-19 workers, and we felicitated the dietitians who worked with COVID-19 patients in India in April 2021. We were very proud of this particular activity, and we are very grateful to the supporters of this event. And of course, our constructive efforts on social media have been very highly appreciated, which is evident from the increasing number of likes on our YouTube as well as Facebook handles. And very soon we will be also on starting our Twitter handle. And all this information on various activities that we have been conducting can be accessed on our website. I request all of you to visit our website and benefit from that, because most of these events are available, the content is available on our website. And now, before introducing the new team to all of you, firstly, on behalf of my current local executive committee team, whoever is there currently in the meeting, I request all of you to switch on your videos. And I would like to express my heartfelt thanks to the parent body Nutrition Society of India headquarters for having given us this wonderful opportunity to serve the community. This has indeed enabled me to meet my dream of serving the community as a nutritionist. And our team has think alike people. All of us were dedicated nutritionists. I'm very proud to say that. And it's not only that we could contribute, but we could get experts from within India and outside India to contribute their expertise and thereby benefit the various sections of community, which included students, academicians, researchers, etc. So we are very proud of our team, and we are very thankful to the headquarters once again for having given me this wonderful opportunity. And on my personal behalf, I would like to thank Dr. Subbulakshmi, who has been a motivation behind me, who has motivated me always to be associated with Nutrition Society of India, which I will continue to do it. And also I'm thankful to Dr. Kasturi Sendre, who has persuaded me till I took up the convenership. And I'm very thankful to all my team members who have been strongly supporting me in whatever plans I make and whatever ideas I come up with. And by God's grace, all our efforts have been very, very successful. So with this, I thank all of you once again before announcing the new team. It's my proud privilege to announce the new team who will be taking over the chapter to new heights. Our new convener is going to be Mrs. Anuradha Shekhar. She will be supported by Dr. Rupali Sengupta as secretary. And the treasurer will be Dr. Neha Joshi. And I will be, as per the guidelines of the headquarters, I will be the former convener. I have served the chapter for 2 terms as a convener, and I have had excellent experience in this role. So I will be one of the ex officio members of the local executive committee. And these are the local executive committee members. So we have Dr. Neha Sanbalka, Mrs. Mad, and I'm very happy to say that this time in the local executive committee, we have representatives from various academic institutions. This is also as after following the guidelines given by the headquarters. We have Mrs. Madhvi Sathe representing MP Shah College of Arts and Commerce, and we have Mrs. Shama Chavan representing Maniben Nanavati Women's College. We have Dr. Priyanka Parikh representing MGM School of Biomedical Sciences, Dr. Mineli Rodrigues representing Nirmala Niketan College of Home Science, and Ms. Amrita Behel representing Srimati P.N. Doshi Women's College. And the head of the Department of Food Science and Nutrition from Dr. BMN College, Mrs. Vinaya Vaishampayan, will also be an ex officio member of the executive committee as per the guidelines of our headquarters. And I'm sure she is going to support Dr. Rupali Sengupta and the entire team in our activities. And our social media team has also been revamped, and we have included new members in this who have been enthusiastically participating in all the social media activities. And now onwards, Mrs. Chandni Chopra will be coordinating the activities of social media team. And since there are many organizations and there are many members, life members of Nutrition Society of India who have been supporting us directly or indirectly, we wish to have another committee which is titled by our own chapter as Executive Working Committee. And we wish to avail the services and contribution of Dr. Veena Yati, Dr. Anuradha Mitra, Mrs. Asya Radiowala, Principal Anjuman Islam College, and Dr. Sheetal Gupta, Joint Director, FSSAA, Dr. Rupal Dalal, Adjunct Faculty, IIT Mumbai, Dr. Monal Velangi, Senior Dietitian, KJ Somaya Hospital, Mrs. Purvi Mahajan, Chief Dietitian, Tata Memorial Hospital, and Dr. Nisha Vellari, Assistant Professor from SVT College of Home Science. We want to include all those representing various other institutions and strengthen the activities of NSI Mumbai chapter. So I'm sure with the cooperation of all of you, the chapter is going to shine manifold, and it is going to conduct more and more activities, workshops, and we will be very soon going offline. And so we can aim high, and we will be supporting all the objectives of our headquarters. So with this, I would like to thank all of you, all the members of NSI Mumbai chapter, for supporting us throughout. And I welcome the new team to take over. And I now welcome Mrs. Anuradha Shekhar to officially take the charge. And the new team will be effective as the local executive committee from 1st April onwards.
So on behalf of the new committee, I really thank the guidance, the way in which Dr. Subhadra trained me. Under her leadership, I have really grown, nurtured, but I'm sure I still need her to take this forward. And as a team, as you can see, the number of people who have been added, and I know even the students are now being encouraged to join NSI because of the kind of activities that we are taking up. I want all of your, I think, assistance in charting out a lovely program in which not only the academicians win, but I think the industry, the students, especially the students, the young dietitians, the nutritionists are all going to come together and nurture NSI Mumbai chapter to further heights. And I'm sure being in Mumbai, it is possible because we can connect to so many NGOs, to all the organizations who are already representing in this particular meet. So I'm very, very thankful to all the colleges for joining us. And I'm expecting a lot from each one of you. And thank you very much for choosing me as the convener. But I'm really depending on all of you to contribute. Spare me, as I am pretty old right now. So young blood should come in and help us grow and nurture NSI Mumbai chapter. Thank you very much, Dr. Subhadra and the entire team for choosing me and giving me this opportunity to raise or to take the NSI flag much higher and beyond. Thank you very, very much.
All the very best, Mrs. Anuradha. All of us are going to be with you. And we have worked as a team, we will work as a team. And now we have much more support from the other academic institutions who were not formally in it. Informally, of course, they have been supporting us. Now formally, they are also with us. So we will involve everybody, each and every one, and we'll plan very, very exciting activities. I'm very happy that very soon we'll be going offline. So every institute and all the students and researchers associated with every institute will be our beneficiaries, and will pass on these benefits to the community, not only within Mumbai, around Mumbai and within Maharashtra as well. Because we have done many programs even outside Mumbai. Our volunteers have gone outside Mumbai into rural and tribal areas, and they have conducted nutrition education programs and training of the trained. So we will continue to do all these activities, and all our support is going to be with you. We all going to work together. So now, once again, congratulating the entire team. I now invite Dr. Neha Joshi to make certain announcements regarding today's webinar. Over to you, Neha.
Thank you, ma'am. Quickly share my slide. So there are some instructions for certificates. Feedback form link has already been sent to all the participants. You will be able to fill the form only after the session today and will be active till tomorrow midnight. All the participants are requested to fill the feedback form. The certificate will be sent to all the participants by 30th March 2022. Please do not send us any emails asking for certificate prior to this date. Download and save the certificate from Google Drive link as soon as you receive the email. Session will be available on YouTube and can be viewed in the future as well using the link that has been mailed to you all. Thank you once again, all of you, for attending today's session. Stay fit, stay healthy.